Good morning, everyone. I take this opportunity to thank Dr. Raju for giving me this opportunity, and also congratulate on him for this wonderful meeting. So, slide is not moving. Can you move the slide? Okay, so this is a 38-year-old male patient who had a history of granite slab fell on his knee 2 weeks back to present to us. He had a feeling of the knee dislocated and then self-relocated en route to the hospital. He was shown to some local hospital, and further after that he was immobilized in just a knee brace, and he had a pain and instability and unable to walk. So on the examination, he had the medial side dimple sign. So what is a similar case of Dr. Arvind's presentation? So coming to ARS, what are the causes for puckering sign on the medial side? Can we have the options? Medial side puckering. So definitely a ligament and the retinacular injury, it is very obvious. And so I'll just show a few examples of other puckering. So there can be a medial puckering or anterior puckering, but I'm not sure about the lateral and the posterior puckering, which we have not seen it. So this is another example where there was a medial puckering and there was a type 1 open wound with the abrasion, and we can see that the joint is the subluxated position. And this is another case of anterior puckering where we can see that the skin has invaginated into the joint, and that is because of the tethering of the skin and the soft tissue, and it gets caught in between. And once the knee is reduced, the puckering disappears. The anterior puckering disappears once the joint is reduced. But whereas the medial puckering of the skin does not reduce because of the soft tissue involvement. So coming back to our case, this patient had a grade 2 anterior and posterior laxity, and the Latchman was positive, anterior drawer grade 2 to grade 3, and valgus was grade 3 at 0 degree, whereas there was some opening was there, but that's because of the subluxated knee, I guess. And at 30 degree also there was a grade 3 valgus was there. So this is the pre-op X-ray at 2 weeks. Our case, the posterolateral subluxation of the knee, where we can see that the joint is not completely reduced. So though the patient, it was not reduced in the hospital, but patient has told that it's a kind of a transient dislocation where it was reduced. So what is the cause for a irreducible knee or the subluxation after the reduction? We'll go for the ARS for this. So it is no doubt that there is all of the above. So the buttonholing effect can cause the irreducible knee, the MCL invagination, or the rim fractures can cause. So other example, the same case, the first case what I told, it was not able to reduce it. So here we can see that, and then the buttonholing effect happens because there is a rent in the retinaculum which pushes out the medial condyle, and then the MCL goes inside the knee. So this being the cause for irreducible knee, so it has to be opened and then reduced. And then the joint was reduced. The another case is an example of a rim fracture. It can cause a persistent subluxation or a dislocation. So unless we fix the bone, there could be the persistent dislocation can happen. So back to our case, this with the dimple sign with valgus. Valgus, we can see the MRI, there was a ACL and PCL tear was there. And in the medial compartment, we can see that there was soft tissue which has gone inside the medial compartment. That is a combination of both retinaculum and the MCL. So here the Here in the sagittal section as well, we can see that there is a soft tissue inside the medial compartment, where it is not because of any bucket handle tear or flip meniscus, but double shadow is because of the retinaculum is invaginated into the joint. And here in the coronal as well, we can see that because of this invagination, the part of the tissue goes inside, and that's what causes puckering in the skin. So with this background, so what is the mode of approach for this? KD3M, single stage, two stage, collateral first, cruciate first, or multiple stages, X-fix, collateral and cruciate. Oh, okay. So there is a confusion. So we can see that once this complex case comes, all possibilities can be attempted, like a single stage or a collateral or cruciate and this thing. So the timeline in management of these cases would be once knee dislocation happens. Some of the one of the audience questions was this. So we reduce the knee, look for neurovascular, then immobilize the knee. Just in knee brace would be sufficient. If it is too unstable and then a lot of rotation happens, then we can put an X-fix. And then after 1 week, we can gain the movement. And then what we follow in our institute is a cruciate first, and then we address the collateral, both in the single stage as well. So here we can see that the soft tissue invagination, where the MCL, the retinaculum has gone inside and it is almost near the notch. And it was very difficult to release that or push away, even though it is acute case. It was difficult to push away the soft tissue away, and each time when we push it away, it gets inside. So this happens because of the rubber band effect of the soft tissues, where the retinaculum goes inside unless we release a bit of retinaculum. So here I have released it arthroscopically as well to get away the rubber band effect and then reduce the joint. So in our institute, we follow the cruciate first policy. Just first see how much of medial space opens up after the pushing away, then the PCL, then the ACL, then again check the medial space, measure it, and then we do the collateral. So we have published our results of 45 cases in 2018 in OJSM, and this is a flow chart from our study. So here, after reduction of the soft tissue, we go and see how much of medial opening happens. So in this case, it was more than 12 to 14 mm of opening was there. So and then proceeded with the single stage reconstruction, that is PCL. So first the PCL femoral tunnel and the ACL femoral tunnel, and then the tibial tunnel, the standard procedure. So the graft is being passed here. First the PCL graft, railroaded and then fixed with fixed loop, and then after PCL, then the ACL graft is being passed. So ACL PCL alone will reduce the amount of medial side opening, but definitely needs a MCL needs to be managed as well. So here we can see that there is a almost 2 to 5 mm of reduction in the medial space, and the medial space opening was just about 10 mm. So the dilemma here is in this case, so obviously this case was grade 3 because it was more than 10 mm of opening. So what should be done? So this is an acute case, repair or reconstruction, or how to manage for the femoral side, mid substance and tibial tear. So these are the dilemmas in the MCL management. So E4 guidelines tells that repair can be done within 3 weeks, and more than 3 weeks, what happens is the integrity of soft tissue won't be delineated, and then the poor definition of soft tissue would be difficult for to do repair because everything would be a fibrous tissue around the medial side.